السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم في case of the week 5 on our channel 4D Passion. Here's a case of our first gynecological case. A virgin female 20 years old referred for my center for 3D scan because of severe dysmenorrhea. On initial examination of the abdominal ultrasound, you will find a mass partially exophyting from the uterine fundus measuring about 3 cm in diameter. You will notice that the mass consists of echogenic central core surrounded by an isocoic rim with a thin rim separating both inner core and peripheral isocoic rim. You will also notice a small cystic area within the central echogenic core, and the mass is surrounded by a rim of peripheral vascularity on color Doppler. On 3D rendering, you will notice that the echogenic core is separated by myometrium from the eunormal in uterine endometrium. And on multiplanar imaging, you will also notice both in coronal and axial plane the separating cleavage myometrial plane from between both endometrium and the mass lesion. And also on multiplanar coronal imaging, you will notice the separating cleavage myometrial plane. On analyzing the mass with TUI multiplanar imaging and VCI, you will notice that the mass actually contains the central echogenic core that contains a small cystic area and separated by a thin hypocoic rim from peripheral isocoic ring-like structure. So the findings in the case were a subtotally exophytic mass lesion measuring 3 cm in diameter arising to the left of the uterine fundus and separable from the left ovary. The lesion has an echogenic core that contains a cystic area and is separated by a thin hypocoic rim from peripheral circumferential isocoic thick ring. The lesion is surrounded by a rim of peripheral vascularity on color Doppler. All findings in a young female complaining of severe dysmenorrhea. So the diagnosis is accessory and cavitated uterine mass. Accessory and cavitated uterine mass is a condition defined by the presence of an uncommunicating uterine mass close to the insertion of round ligament. ACUM is a rare Mullerian anomaly found in young women and is diagnosed by the presence of central cavity in the uterus lined by functional endometrium and surrounded by a ring of smooth muscle. The criteria used to diagnose the ACUM are as follows: an isolated accessory cavitated mass, a normal uterus with normal endometrial lumen, fallopian tubes and ovaries, surgical evidence with an excised mass and pathological findings, an accessory cavity lined by endometrium epithelium with glands and stroma on pathology, and chocolate brown colored fluid content, no adenomyosis. Most cases of accessory and cavitated uterine mass have been diagnosed in women aged less than 30 years and those who are nulliparous who have severe dysmenorrhea. However, some cases have been reported in women who are older than 30 years or are multiparous. ACUM causes severe dysmenorrhea and recurrent pelvic pain in young women, refractory to conventional analgesia and hormonal therapy, usually requiring surgical treatment. Since most of these patients will wish to preserve fertility, excision of the tumor without hysterectomy is often the treatment of choice. However, hysterectomy should be recommended for patients who have no desire to conceive because this can permanently relieve their dysmenorrhea. There is a tendency to misdiagnose ACUM as a cystic adenomyoma. However, a cystic adenomyoma consists of endometrial glands surrounded by endometrial type stroma and smooth muscles that lack the uterus-like tissue found in ACUM that is seen here in our case. MRI may facilitate timely diagnosis because it can define hemorrhagic content of fluid and can also will depict the myometrial periphery. As with all Mullerian anomalies, abdominal imaging to exclude urinary tract anomalies is recommended prior to surgery. Here is a case from the web with MRI showing an accessory cavitated uterine mass that shows peripheral isocoic myometrial-like tissue and central echogenic core. And here on laparoscopy, the mass is seen in between the uterine fundus and round ligament. And on pathology, the mass has a central cyst that contains brown chocolate-like fluid. With central cavity and lining endometrial glands on histopathology. So the take-home message: Please don't rush to diagnosis, as ultrasound needs patience. In this case, a diagnosis of cystic adenomyosis or degenerative fibroid could be an easy option, but a misdiagnosis. A mass is not just a bump. We should analyze the infrastructure of the lesion. Even in a virgin female with ultrasound done by a transabdominal convex 4D probe, good acquisition of 3D volumes and good editing is very additive to the diagnosis. Kind regards and see you soon. السلام عليكم ورحمة الله وبركاته. دكتور عمرو فاروق.